everybody, or good afternoon. Thank you so much for joining us today. My name is Chelsea Kimura, and I'm a training and technical specialist with the Northwest ATTC, and I'm here to help support this session today. My colleague Mandy is also on the session today, so please feel free to message me or Mandy during the session if you do run into any technical issues. I also want to note that this session is being recorded, and the recording will be available on our website in just a few short weeks for you to view and share with others. And then just a quick friendly reminder, you will be eligible to receive a certificate of completion for today's session. To meet our credentialing requirements, though, you will need to stay with us for the whole session, so do please keep that in mind. And I'm very excited to introduce our presenter, Dr. Kate Speck, but first we do have a land acknowledgement we want to share with you on a couple other slides. Perfect, thank you, Kate. So our work intends to reach the addiction workforce in HHS Region 10. This includes Alaska, Idaho, Oregon, and Washington. This region rests on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join us in support of efforts to affirm tribal sovereignty and in displaying respect and gratitude for our indigenous neighbors. We're all coming from different regions in the Northwest area today. I reside on the original homelands of the Siletz, the Grand Ronde, Umatilla, and the Walla Walla tribes. I do encourage you to look up which traditional homelands you reside on and share in the chat if you're able, and Mandy will share that link for you all. So please do feel free to add your locations to the chat when you have them. All right, next slide, please, Kate. Oh, perfect. Okay, most of you are probably familiar with the ATTC network, but if not, this is a map that shows the whole network. The ATTC network includes 10 US-based centers and a network coordinating office. Our team works out of the Northwest ATTC, so we serve organizations and communities that are located in Alaska, Idaho, Oregon, and Washington. We are grant funded by SAMHSA, and through our work, we're able to provide educational and consultative services that promote the adoption and the implementation of treatment and recovery practices. Next slide, please. All right, and we do have a quick survey for you all. I think Mandy already added that to the chat, but please do take a second to either scan the QR code here or grab that link from the chat, and then we will have a quick survey at the end of the session as well. So maybe we could give people just a second here, and then we can jump to the next slide when you're ready, Kate. All right, and now it's time to introduce Kate. So Dr. Kate Speck has more than 44 years of experience as an educator and a trainer in behavioral health. She's directed addiction treatment programming in Iowa, Louisiana, and Nebraska. Kate has instructed master level courses in substance use disorders, psychology, theories of personality, and ethics. She has a strong background in prevention and intervention, substance use in families, and with pregnant and parenting women. Kate is a master trainer in suicide prevention, disaster preparedness, psychological first aid, and motivational interviewing. She is a member of the Motivational Interviewing Network of Trainers and is associated with the University of Nebraska Public Policy Center as a senior research manager on call. All right, Kate, I'm going to turn it over to you. Thank you for being here with us today. We're excited.
Thank you so much, Chelsea. And I also want to thank Mandy. You guys get everything taken care of in the background, and it's really appreciated. I have to tell you, they are stellar. So thank you for that. And thank you all for joining us today. I'm going to give a land acknowledgement of my own just before we get started. Because I come from Nebraska, and I've got that little map up there of the United States where Nebraska is. And I want to acknowledge that I reside in a state that is currently on the homelands of indigenous peoples of 27 tribes, and that have a connection to our land, which is currently, again, known as Nebraska. And I want to say that I have respect for the stewardship and conservation of the land. And I also want to recognize it's my responsibility to establish and maintain those relationships on the land that we are on here. So just to give you a little bit of familiarization to where I'm coming to you from. So thank you again for being here. And I want to share with you that I have had the wonderful opportunity to attend the previous 3 sessions in this series. And I just want to also let you know that this will be a little different than all of those 3 sessions, right? Because you had a session with Dr. Miller, you had a session with Paul Warren, and then you had a session with, I can't remember her name from last week, but it was a great session, the psychiatrist who talked a little bit about personality disorders. And so I'm always interested in that kind of stuff. I'm fascinated about those kinds of things. And so what I'm going to do is talk with you a little little bit about the workshop that I hope that will bring you information and so forth related to motivational interviewing in the context of co-occurring disorders and with criminal justice clients. So we'll probably hold those questions to the end. Please let Mandy or Chelsea know if you have questions. If there's a need for us to stop in between, I'm real glad to do that also. So Chelsea and Mandy, if you have somebody has a question or anything like that, you can certainly please interrupt me. Now, if there's something on a particular slide, you have the slides, and I'll talk a little bit about the handouts in a moment when we get through a little bit stuff here. Let us know that you did or did not get those handouts, because there's a couple of them I really want to make sure that you have, and I'll talk about those down the road here. So once again, any questions and things like that. Now, I'm an adult learning educator, so I'm like the classroom teacher. However, and this is not going to be a real interactive portion right at first, because I have a lot of information I want to share with you. And again, once again, in that context of how do we use motivational interviewing. So we'll get those, if you did not get the slides or things like that, just let them know, they'll get them to you. All right. So basically what I really wanted to do in this particular workshop was really talk a bit about the motivational interviewing strategies and how do we kind of get those in line with the individuals that we're serving. Many of us are working with individuals who are justice involved, we call them, but those justice involved individuals also have the unfortunate situation of often having not only substance use disorder, but other mental health disorders that or conditions that may be interfering with their success. And so we want to understand those really complex situations and their complex needs, and make sure that we're really honing in on how can we be most effective as clinicians when it comes to working in that context. And then also, I want to do a little bit of I guess, contact with maybe a couple of case studies that we have that we're going to do at the very end, and talk a bit about how is it that we're really making sense of the use of motivational interviewing strategies in those contexts. So some of us are working with people who are currently incarcerated. Some of us are working with people who have previously been incarcerated or who are on probation. And so once again, it's a way for us to, motivational interviewing is a way for us to hopefully play into the success that we'd like them to have as they transition out of incarceration, or just living outside of the system, if you will. And so I've kind of set this up to say we're going to try to recognize and respond effectively to change talk and sustain talk. Now, I'm just going to assume that every one of you have already attended one of the previous workshops where Paul Warren did a fabulous job in talking about, how do we use motivational interviewing in many different ways. And so if you have a question about any of the information I'm putting in here, please let Chelsea or Mandy know that, and then we'll hopefully use those as questions at the very end. So we'll talk a little bit about change talk and sustain talk. I also want to demonstrate some motivational interviewing strategies, and so we'll have a little ready for not primetime players with Mandy and Chelsea at the very end. So we're going to talk a little bit about, are we recognizing the strategies that we're actually using? And then we'll talk a bit about what are some of the indicators of change? How do we know that somebody's ready for change, right? So, and I'll talk a bit about, how do we come to that conclusion? All right. And so I first want to set the context in terms of a publication that I think would be very helpful for all of us to have. These are your tax dollars at work. Tip number 42, treatment improvement protocol number 42. And I have a little picture of it up here on the right. Well, I guess it'd be the right hand of the screen, just above. Tip number 42 from SAMHSA. It's a free download. This is the one that has been most recently updated. I think it was probably 4 years ago that it was updated. However, that booklet has a lot of great information in it for you as a clinician in relation to how do we use, how do we address co-occurring disorders. So I think what I love about these 6 guiding principles in working with, in general, these are not justice involved individuals. However, there is a section in this book that is, that talks a bit about justice involved clients. So there are 6 different elements here, and I'm going to go over those just because I want you to have a good understanding of those. First of all, I want to talk a bit about the recovery perspective. So, it's kind of like, well, oh yeah, we believe in recovery, right? Well, what is the recovery perspective? The recovery perspective has 2 main features, and the 2 main features are, number one, we have to acknowledge that recovery is a long-term process that involves internal change and external change, of course, right? And so and we have a lot of work that has been done on the change process, not only by Dr. Miller and Dr. Rolnick with motivational interviewing, but with Dr. Carlo Di Clemente and James Prochaska. And those 2 individuals kind of introduced to us the stages of change. And so once again, that's used a lot to kind of help people think about how is it that people change, right? And so we look at what that recovery is, that long-term process, recognizing that to go through various changes, it takes some time to do that, right? Also, we want to adopt what we call a multi-problem viewpoint, and that simply means that people with co-occurring disorders generally have an array of different kinds of things going on with them. Not only might they have, maybe a substance use issue, but they may have a condition of a mental health concern. They may have medical concerns. And sometimes we end up leaving out the fact that there are 3 different types of things there: medical, mental, substance use. But also, you well know this as I do, family concerns, what's going on in their relationships. What about the social issues that are kind of impacting individuals? Are they able to receive services? Are they home? Are they housed? So a lot of the different kinds of things that are going on with that. So we talk about a phased approach to treatment, right? So that we're not just going to go hard and heavy right away. Let's get people in treatment and get them comfortable with us, and then we can begin to maybe dig into some of the complexities that go along with their lives. Also, we talk about, the real problems that we have to see in early treatment. And lots of times people that come into treatment, they are not so happy about it, or they're so ridden with guilt or shame that it renders a lot of the things that we're doing ineffective until they kind of work through the grief process of loss, of how they got there. So we want to also pay attention to number 5, where we talk about the person's cognitive and functional impairments. What does that mean? Well, when a person comes in under the influence, when a person comes in and they're under a large amount of stress, or they're having symptoms of their disorders or their conditions, they may not be up and running. In other words, they may not be able to really get what we're saying to the deeper level of where it needs to be. So we need to continue to repeat that, or make sure that that person is really able to track what we're doing and kind of not just play along with, but actually involve themselves in the treatment process itself. And then, of course, those support systems that are ever so important. And those support systems can be many. They can be, again, maybe the recovery meetings in the community. They can also be faith-based communities. They can be peer support and recovery processes and so forth, and many others. And so once again, we want to set that context up for where we're going to go next. So in SAMHSA's tip number 42, that term of co-occurring substance use disorders and mental disorders, right? We have more than one at a time. And sometimes there may be more than 2, right? So it could be a lot more complicated. But what we're really saying is that these situations are coexisting in the same person, and we have to treat them both. Now, years and years ago, we used to say, well, let's get rid of the substance use first, then we can work on the mental health stuff. Or let's get the mental health stuff under control, then we can work on the substance use stuff. Well, that wasn't very effective, right? It kind of put people into silos, their disorders into silos. It didn't really help a lot. And so the co-occurring theme really came about as really saying we've got to treat both at the same time. Now, you'll see here a list is kind of a little bit of history of terms. But over the years, all those things that are crossed out are typical terms that we used to use to kind of identify those individuals that we're serving, right? So right now we're using the terms dual diagnosis or dually diagnosed. And that's going to change soon. You're going to see a change in that soon because we're going to be calling those things co-occurring conditions, right? They're conditions. So rather than, some, people might say, I listened to somebody talk about her horrific experience in her life. I guess it was like 27 years ago that she was describing. And she talked about how it really hurt her in a way to think about her post-traumatic stress. And she said, it's not a disorder. She said, it was an injury. It's something that happened to me. And I really love that change. It's like, oh, it's not so much something, it's a condition, but it's also an injury. And that made me understand her discussion with me and the things that she was telling me from a different perspective. And I really loved that. So disorder is what we tend to do with the DSM-5, and you all know that. And we have to have a common language. Unfortunately, we label people. The people end up labeled. I don't say we label them, but people end up labeled so that we can have a common conversation about what's going on with them, right? So another thing that's kind of big, and again, I'm setting us up to really think about all of these things, is trauma. And of course, the question I have on there, how common is it? We know how common it is. And if you all want to put in the chat feature, I would just love it if you put in the chat feature the percentage of individuals that you have in your, the people that you're working with, the percentage, how many people are affected by trauma that you are seeing right now in your practice, or just the work that you're doing. So look at here, we have 100%, 100%, 80%. Yeah, look, high percentages of that. Absolutely. Thank you for that. Oh, I love, Barclay, what you did there. I don't know how you did that so fancy, but I like that fancy thing that you did. And so, yeah, so we know that it is a pervasive part of what's going on. And is trauma really a diagnosis? Well, we have to have post-traumatic stress disorder to do that. But once again, a lot of people don't consider some of the traumatic events that they have had in their lives. The statistics here that I've shown, once again, they're in your handouts. I'm not going to read them to you, but we have to really take a look at the issue of how are we incorporating trauma-informed care as well. So there's a heavy load on you all, right? It's a heavy load on clinicians because we have to think about so many complexities. We have to think about so many different things that may be happening with the folks that we are serving. And so the thing that we try to have bring us together is this DSM-5, right? It helps us describe what's really going on. It helps us to kind of take a look at, and maybe to get descriptions of, yeah, it helps with payment because we have to have payment for our services as well. And so the DSM-5 TR now, and of course there'll be continued revisions of this document as we learn more, right? And so now we have trauma in the DSM. So if you just take a look at that list of different kinds of things, these are specific to trauma, right? And so I just want people to have a good look at that and think about the people that you're serving right now that have that may have one or more of these situations that are that are considered to be stressors when it comes to not just substance use disorders, but additional mental health disorders. Now, I'm going to ask you to ask yourself, right? And you can raise your hand or you can put it in the chat feature, whatever ask yourself, in the last 12 months, have I worked with someone who has the following disorders in combination with substance use? So just think about that. Think about what you are experiencing right now with folks that you are serving. So I have a few here that are part of our world, or we have additional ones, right? The ones that were on the previous slide, right? So we have a lot of things that we have to kind of watch out for and kind of hang in with, especially in order to do the best job that we can do for our clients. And I'm of the true belief that people don't get into this field, or I should say, people get into this field because they care, right? And we get into this field, and because of that, we too can become injured, right? With compassion fatigue because we care, because we want to do something good for our clients, especially in the context of the complexities that they are experiencing. So, why are we using motivational interviewing with justice involved clients? Well, number one, what are we trying to do? We're trying to get that person to open up to us. We want to build that trust with them. We want them to feel safe, especially those people who have had experiences of trauma and who are suffering any of the mental health disorders, whether those disorders are kind of, oh, I used to be depressed, but I'm not depressed anymore, or yeah, I still have a little bit of anxiety, but it's not as bad as it was, or it's really, it's really been bad lately, right? So different things in our lives affect us in different ways. So motivational interviewing is a way for us to build trust and help people feel safe. Safety is the most important thing here, again, for trust. The other thing that we look at with motivational interviewing in terms of what the research tells us is that engagement, being able to engage with a person. Now, there's lots of different ways that we can engage and so forth. However, if you're working with justice involved clients, you're going to see that they may have a hardened distrust of systems. And we'll talk a little bit about our role in those systems down the road here. So when we talk about a person, enhancing engagement, when they're feeling off balance, right? And we talk about the ambivalence. I should get help. I want to get help, but should I trust this person one way or the other? That ambivalence starts to really rise up to the surface. And ambivalence is around because it's normal. It's natural. There's nothing wrong with it that people are going to feel that way. So we want to normalize that, and we want to normalize that they might not feel comfortable with us as well. So motivational interviewing can really help us kind of get on a trust level that helps engagement take place with that person. The other thing that motivational interviewing does is, when used correctly, it helps the client to self-reflect. They're reflecting what's going on within themselves. They're questioning their own behaviors, their own thoughts, and so forth. And we want that. We want them to be able to do that. To be able, that's where they've got to kind of come on to the realizations themselves, right? About, what's going on, and if they are going to make that choice for change. We're not able to do that for them, even as much as we want to. The other thing is that we want to think about how it may foster these positive outcomes, right? So again, we've shown that in a lot of domains. We have a number of clinical research studies that have been done that show the effectiveness and the impact that motivational interviewing does. So why are we using it? Well, we got evidence. We have evidence that helps us to understand what's happening in those conversations that we're having that are based on motivational interviewing. Now, this is just one study that I've got here, and I promise you I won't get into the academic nerd stuff with you, but I do think it's important for us to know that motivational interviewing has an evidence base, and it's been shown over and over and over again in about 1,800 clinical studies that it works in several different domains, right? And so, the criminal justice, should I say, system took on motivational interviewing in about 2012. And they started saying, we're going to train all our probation officers. We're going to train all these people and so forth. And that was a big change. That was a huge change. This particular study wasn't done in relationship to criminal justice. However, I wanted to show you again that the importance of us, how we listen to people, right? So when what we hear, so, and I know Paul Warren talks a lot about using your eyes, your ears, your heart, and your gut to really get into that understanding of a person. But once again, what are we actually hearing? So those are going to be very powerful for us when we really are listening. So the change talk that we go after, we try to, we go after that change talk. We set those conversations up to enhance change talk. We normalize ambivalence so that we can hear both the change talk and the sustained talk. And at the same time, we intentionally put our conversations toward what the person is remarking about, what they'd like to do in terms of a positive behavior change. So this particular study was doing with drinking outcomes, but I've highlighted at the bottom, the client speech impacts the likelihood of behavior change. That doesn't mean that motivational interviewing is the miracle that, of course, we'd all want that. But once again, there are things that we have done to figure out that how we can impact client speech in a way that helps lead them in a way that they make the decision changes something I might want. And so once again, we're going to make sure there's safety. We're going to normalize ambivalence, and we're going to respect their autonomy to make a choice for themselves. And if I have time, I'll tell you about my brother who's just got caught smoking dope in the nursing home recently. So I'll tell you what, as a family, we're all mad as the dickens with him. But once again, he's, it's a choice. So when you think about implementing motivational interviewing with criminal justice, or I call it justice involved, because you don't never necessarily. So lots of times we have this criminalization thing, and it can be kind of a damaging moniker to put on somebody. You're labeling somebody as a criminal. So I just call it criminal. I call it, justice involved clients, right? So once again, think about ambivalence. People are torn, and it's not a fun feeling to feel that icky inside, to be torn apart by should I or shouldn't I. And you all know this. When you think about making a decision for yourself, and it doesn't have to be about anything big, it's like should I or shouldn't I. We're doing that all the time. It's a good thing for us to be able to do that, because once again, we're in charge of our lives. So motivational interviewing created to explore and resolve ambivalence. Enhancing motivation for treatment. Right. So what are we trying to do? What we're hoping to do is help a person make a decision toward intentionally involving themselves in treatment, in the treatment strategies that we're working with them. And once again, we are, there's bias there. We're definitely biased. We want the person not to go back to jail. We want that person to live in a healthy, productive lifestyle or relationships, etc. And so, yeah, we are biased, and we better own that, right? And we have to own that, because if we don't, right, it's like, what do we want for our clients? I want for my clients to do well and to leave my services in a way that gives them a better life. And that's a good thing. There's nothing wrong with us wanting that for our clients or moving in that direction for them, right? So we also have to normalize those struggles as well. Because once again, we think about how the setbacks that happen, and if you're working with folks who have co-occurring disorders, you're going to have more setbacks than you would with somebody who doesn't have a mental health disorder on top of a substance use disorder. So that's just going to be something that we have to kind of take a look at and think about the long-term pieces when it comes to long-term. We're going for a long-term recovery. It's going to take a minute, for us to get there, right? So I'm going to talk a little bit about your handout now. And there you'll have this. I'm going to bring it up on the screen so that you can see it. And please let me know if you can see this. Chelsea, can you give me a thumbs up if you can see it? Okay, thanks. All right. So what I've done here, and we're going to talk about this in a little bit here, but what I've done here is I've outlined for you addressing the criminogenic need. I'm going to explain that in a little bit, what that is with clients with co-occurring disorders. And so what I've done is I've outlined what is used typically in criminal justice or with probation or those individuals who are working in institutions. The big 8 criminogenic needs. And these are going to be really important for you to kind of take note of. And I'll go through these just in just a little bit. Okay. The other thing that's really important that I put in here is why this matters for you, right? Because of the high overlap that we have with justice-involved clients and substance use disorders. What kind of treatment impact is that going to make? And then again, client engagement. Now, there's something else, a couple of things in here that I put that you need to be aware of that justice uses to assess clients, right? When you get a client, when they get referred to you, and they're coming from a criminal justice setting, it's usually because they have been assessed by the criminal justice system, whether it's a court order or whether it's a situation in which their probation officer says, well, these are the requirements of probation. And if you want to do well in probation, I'm going to refer you to XYZ clinic or XYZ counselor. And then I'm going to work with that counselor and we're going to communicate. But there's a reason for you to need to be in these services. So they do their own assessment, and and not everyone that I'm saying here, that they may use different assessment tools. Please ask the people that you're working with in criminal justice, please ask them what assessment tools they are using. What is being used right now? Why did this client come to me? Yeah, I'm a substance use counselor, I'm a mental health counselor. How do you know this client needs to be in my services, right? Does it make sense? So they use a couple of different things. One of them is the LSI, and that's called the level of service inventory. They might use the ORAS or the COMPAS. But once again, these are to identify the criminogenic needs, which we're going to get to. All right. And then again, these are the best practices. What are the screening tools? How are you collaborating with the officers, the parole officers, the probation officers, the courts, right? And that's important for us to do. Are we using specific evidence-based practices that we know work with criminal justice, right? Because that's CBT for sure, right? And so once again, you take a look at what I've got in the handout and where you can get some of these materials. So it's important for us to really think about. So I've outlined for you in here what each of these actually do, so that you have a little bit of knowledge about that, and that you can ask folks in the criminal justice system what they're using, right? Now, it may be different if you're working in a correctional system, right? So maybe you're working with people who are in an institution, right? They might be in the county jail, they might be in a state facility, and so forth. So there's different kinds of things that are used, and you need to be familiar with those in order to be effective with co-occurring disorders in criminal justice settings. All right, so I've got a few of those things in there, and I've got also then some of the micro skills here with motivational interviewing just for you. How are we doing with implementing it? And then talking a little bit about the challenges, and I'll talk about those a little bit later too. I've got a list of resources for you, and then you have our slides, okay? So that's the handout for you, and if you have questions about that, please let us know, and we'll talk about that maybe a little bit at the end of the presentation. All right, so let's go into criminogenic need. Now, what is this? Criminogenic needs have been identified with lots of really great research, right? And what these are behaviors that can be changed. Now, there's things that can't be changed, right? There's certain things that you can't change at all. So it's kind of like, the static effects, the static factors, we call them. You can't change it. A person is 22 years old, or they're 22 years old. There's no changing that. There's no changing some of the past kind of thing, like their past criminal history. There's no changing the fact that they may have grown up in in an unhoused situation. There's lots of different things that can't be changed, right? But these are what they call criminogenic needs, or directly associated with the person to likely engage in criminal behavior. And it's these things that we are looking at when we're looking at, through the eyes of what we call targeted interventions, right? So the justice system is involved in addressing these types of things to reduce the number of criminal activities that the person might be involved in. So they're looking at all of these, and they have programs. There's lots of different programs that they use. One of them is called Thinking for a Change. And so it incorporates motivational interviewing, but they're really looking at these 8 areas: antisocial cognitions, antisocial associates, right? What do? Do you send a 19-year-old back to their community after there's been, after they're no longer incarcerated, and they go back to the same situation, right? And so that's why, probation and parole, they're so involved in the person's life to make sure that the person goes to maybe a halfway house before they get on the straight and narrow. Antisocial personality patterns. This is your bailiwick. Those of you who are in behavioral health, that's what you do. You look at those things and you say, hey, what is it that we can do to help this person? We can't change personality patterns, but we can certainly work with them on their impulsivity, their aggression, their risk-taking, right? So each of these has not only what they are, but they also have what's the intervention that is used. And that's why people get referred to you to introduce them to these interventions. Of course, substance use is going to be a big part of that. And we have lots of marital and family discord. I call it discord rather than dysfunction. People who don't do well in school, people who don't interact well socially, and people who, again, don't necessarily want to conform to societal norms, I guess I'd say. So low pro-social identity. And we look at these 8 dynamic, we call them dynamic risk factors, because these are the things that are worked on so that we can, again, lots of times substance use disorders, once you treat that and people are in recovery from their substance use disorder, a lot of times there's just no more trouble. There's no more criminal activity, right? And the same may go for specific mental health disorders. But once again, these things are important for us to understand. We call them the big 8. And it's important, I think, if you are aware of these kinds of things and you're talking with officers, law enforcement, well, not just law enforcement, I wouldn't say like the police, but once again, probation, people in the criminal justice systems. And if you're working with attorneys, and if you're working with the courts in any way, shape, or form, right? But there are some challenges with this now. And let's think about these challenges here. So one of the challenges is the thing that we call discord. And individuals, again, discord is this lack of connection. Now, I've got a little phrase in there that says resistant to change. We are no longer using the terminology of resistance because it's very judgmental, right? So we are thinking about this in terms of, the person's ambivalence. What's really coming up now? Is there actual true resistance? Yes, there is. Absolutely, there is. But we are using a different term to kind of think about that, so that we're not putting a person kind of already categorizing them. Oh, they're resistant to change, right? So, and once again, those of us who are in behavioral health, we have different belief systems about that, don't we? We believe in change. We believe that people can we can make a difference, hopefully, when we're working with them. The other thing is, so again, our non-confrontational approach with motivational interviewing is helpful with that. And then there's this complex trauma issue. If there's complex trauma going on, folks, we're going to have a more difficult time in dealing with individuals. And then you want to think about how sustainable is the change? Because a lot of people will tell you, well, I'll quit smoking dope until I'm off probation. And then, I'm going to be back at it, right? As soon as I don't have to report in. And so once again, we're looking for that long-term change. And we have to respect the autonomy of the individual. So when we're thinking about some of the critical aspects of practice within criminal justice, you as a practitioner, you as a part of that system, are really going to need to be clear with your client about your role in that work, right? Again, you have to be sure and maybe even more sure that you are explaining what your role is in working with them as clients, right? And if you have any connection with the legal system, right? So if I'm working with a probation officer and I have to give them weekly reports about what this person is doing in treatment, I have to protect my client at the same time. I have to, be a good reporter for the court, because that is the agreement that I've made with them. So once again, if you give any information you give the client, you just want to really be sure that you're disclosing, and that, I don't necessarily need to disclose my whole client record or all the things they're telling me as a clinician. I don't need to disclose all of that, but I can say whether they're doing well or whether they're not doing well, whether they're showing up or they're not showing up, right? So I don't have to get into the weeds with the probation officers, because that really creates a big conflict for us, right? And so we have that role of protecting our clients, but we also have a role as part of the court, as part of working with the courts to help folks do well with that, right? So being an advocate for our clients is still an important thing. All right, so again, if you're thinking about using motivational interviewing in this context, one of the things that you have to also acknowledge is that you are doing this with intention. You are making intentional moves, and parts of your conversation are going to be intentional. That you are definitely identifying a target behavior. What's the target behavior that the client wants to work on? Yeah, their probation officer says they need to do X, Y, Z, and you think they need to do A, B, C. What does the client want, right? We have to address ambivalence using our spirit. I say spirit, 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 right? Partnership, acceptance, compassion, and empowerment. We have to use the tasks that we use: engage, focus, evoke, and plan. And Paul Warren did a great job explaining all of those kinds of things a couple weeks ago. And then how do we do that? We do that by using our open-ended questions, affirmations, reflections, and summaries. So those are just the critical aspects of practice within that. So I want to now kind of move into looking at a couple of conversations. In these conversations, I just want you to think about, what's really happening here in this conversation. So I've got a gentleman here, and he says, "Look at this scar on my face. I don't know why the police arrested me. I was just defending myself. She's crazy." Now, what would our response be? And you can write in the chat feature if you like this response or you can put thumbs up. We can all have thumbs up, I guess, on our screens, or not. Is this a good conversation, part of the conversation, or would you think through this differently? Okay, so the clinician says, "I hear you. An important part of fixing this problem is accepting responsibility for your behavior. That will help keep you out of jail." All right. Oh, Christopher, you're shaking your head no. Thank you for being on camera. I love that. Yes. All right. Melanie says, "Not so good, not so good." Right. So great. And why? Why is that? Well, let's think about why that is. Number one is, am I inconsistent because there's a direct confrontation to the client? It's very mild, folks. Very mild confrontation, but it says, fixing this, you got to take responsibility here. How nice you say it is one thing, but what is the client going to hear? Oh, crap, right? The provider has taken the side of the client's partner, it's taken the side of the client's partner in the criminal justice system, and is not interested in hearing the client's perspective, right? She's crazy. Well, we didn't ask anything about what happened in that, so it's kind of like, oh, so we're taking sides here. Another reason it's not so consistent with motivational interviewing because it doesn't respect the client's right to make choices. You got to keep out of jail. So we're kind of shaking our finger at them a little bit. It's critical. It's not an affirming kind of statement. And highly likely that this person is going to turn their back on you, right? They're going to say, this person doesn't get me. I don't like this so much. Okay. All right. So I'm going to have that same statement. Look at the scar on my face. I don't know why the police arrested me. I was just defending myself. So here's a second try at this. Let's see if you like this, right? Again, you can thumbs up or thumbs down or however you want to do that. You do not believe that the police listen to your side of the story and are uncertain you belong in this treatment, which is a really nice statement, isn't it? Right? It's a reflection. How can we ensure you keep out of trouble? Okay. So you might say, well, this is better than the first one for sure. It's a lot better than the first one. However, there's some little things that I want you to be aware of in this conversation. Again, not a bad statement at all. But again, the good thing here is that there's not a fixing reflex. Does everybody know what the fixing reflex is? If you know what the fixing reflex is, put a yes in the chat feature. Yeah, Taylor, thanks for giving the thumbs up. If you know what that is, the fixing reflex, we get involved and try to fix it. Absolutely. And so so we're staying out of that. That's a good thing. We like that. The provider also attempts to evoke potential solutions from the client. How can we work together, right, to keep you out of trouble, right? And then there's a little effort to communicate the elements of acceptance. And so once again, in this situation, am I really conveying my acceptance? So when we think about motivational interviewing spirit, right? Partnership, acceptance, compassion, empowerment. So when you think about that, again, is this person really being accepted when it comes to that? All right, so here's a third look at this same conversation. I'm not going to read it again, but let's go with this. So here's what the clinician says. You don't believe that the police listened to your side of the story, which was part of the first one, right? Or the second one. And you're not certain that you belong in this treatment. Now think about what we're conveying to the person. We're conveying to that person, there's a little more under the hood here, right? We're making an attempt to really understand that they feel ambivalent about having to be here, right? Given that you feel that way, I appreciate that you kept this appointment and showed up. So now this would be a statement that would be more engaging to this individual, right? So we talk about this being one thing that conveys that you've heard and understand their perspective, right? You don't believe the police listen to you. You're not certain you should be here, right? The person also, again, we conveys a little bit of empathy. And that affirms the client's willingness to keep the appointment. It goes into a positive thing that the client actually showed up, even though they showed up with their fists out, right? And so these are some things that I want you to be aware of. It's important in our conversations. It's more than just a reflection. It's a deep reflection of what's going on here, right? Intentionally. So my point is here, you get the dog you feed, right? If you feed this dog, you're going to get this dog. If you feed this dog, you're probably going to get this other one, right? And so you want to think about where am I going, when I'm actually, interacting with the client. So now we've got a couple of other case examples. And what I want to do now is I'm going to ask both Mandy and Chelsea if they will help me with this. First, I'm going to read about this case example number 1, and then we have a conversation. I'm going to show you the conversation on the screen, and they're going to read it as part of it. And I want you to really listen to what is happening this. Okay, so Xavier is a 32-year-old male who has had a history of alcohol use since age 12. He was sexually abused by his paternal uncle through the ages of from 6 to 10. He was a runaway and homeless until age 19 and had multiple arrests. He states that he's been diagnosed with depression, ADHD, and bipolar disorder. He's currently on probation for a DUI offense and is not positive toward continued treatment, which is a probation requirement. Okay. So now we're going to get ready for our not ready for prime time players, and I'm going to put this on the screen. So I don't know, Chelsea and Mandy, who wants to be the practitioner and who wants to be the client?
I think I'll be the practitioner and Chelsea will be the client.
Okay, awesome. Thank you. All right, so just go ahead and I'll change the screen when the rest of the conversation comes up. Please listen, folks. Listen to what's being said by the practitioner and the response they're getting from the client. Okay.
Thanks for coming in today. I know continuing these sessions wasn't exactly your choice. How are you feeling about being here?
Honestly, I think it's a waste of time. I did what the court asked, and I don't think I need to keep doing this. I'm not an alcoholic.
I hear you on that. You've done what was required, and it sounds like you're feeling frustrated about being told to keep going with treatment when you don't believe it's necessary.
Exactly. I mean, I had one bad night lately, one mistake after so long of not being arrested in the last year. I've even held a job at the tire store for the last 8 months. That alone means I can control my drinking, and to me means that I don't have a problem.
One night led to some pretty big consequences for you. Court, probation, and this program. I'm curious, what do you think led up to that after so long?
I don't know. I had a few drinks after work like normal, and then someone called needing a ride. I was pulled over for a missing taillight, and I didn't feel drunk, but I guess I was over the limit.
You didn't expect to be pulled over. Drinking after work is routine, things went things went differently. What concerns, if any, do you have about how alcohol fits into your life?
I mean, I guess I don't like the fact that one night changed everything. I have worked hard these last few months, and I've been so careful lately not to get into trouble. I still think I can drink and be fine.
You've made some big changes and you're trying to sustain that, like being more careful. That shows you're already thinking about how to avoid more trouble. What worries you about continuing with services?
I just don't want to be labeled or treated like I have some kind of disease. I don't want to sit in a room and talk about drinking all the time when I'm not even sure it's a big issue.
Yeah, no one likes to feel labeled or boxed in. Since it sounds like you have some reservations, and if it is okay with you, what if we shifted focus a little, less about labeling, more about your goals and whether drinking gets in the way of those?
Uh, I guess I'd be more open to that. I do want to get off of probation. I have to keep my job, and I guess I might need to get back some trust with my mom since she's the only one who really supports me.
Those sound like really important goals: freedom, stability, and rebuilding a relationship with your mom. If we work together, maybe we can explore how alcohol has played a part to help or hurt those things. Would you be open to coming back just to look at that without any pressure to admit a problem?
Maybe if it's not just preaching or pushing me to say I'm an alcoholic or something.
Not at all. This is about you deciding what works best for your life. My role is to help you explore what direction you want to go, not push you in one. Would it be okay if we picked one of your goals next time, whichever makes sense to you, and looked at whether we can sort out if alcohol plays any role in helping or hurting that area?
Yeah, I could do that.
Great. That's a solid step forward. Thanks for being honest with me today. Your perspective really matters here.
All right, clap hands for our actors. Thank you very much. We're going to employ them in a little while. Yes, thank you, Chris. Thanks for doing that. Appreciate that. Yes, lots of people clapping for you, Chelsea and Mandy. Thank you. All right, so right, what did we see? We saw a whole different conversation than maybe I would have had with Xavier years ago, because I would probably have jumped right into the fixing reflex and just jumped right into that. Well, don't you realize what a bad thing it is? And you have such a history, and try to convince them. Here you heard something different. And this was motivational interviewing being employed and listening very critically to what that person was saying and considering their change, so considering the change talk. All right, there wasn't a lot of change talk in there, was it? The person was upset. So here's what the strategies were that were used. First of all, building rapport. Go back and look at that conversation to think about how did we get rapport, reflective listening, right? Restating it in a non-judgmental way. And non-judgmental is critical here. Asking open questions to draw out the client's own reasons for change. Affirming the person's autonomy. They have control. They are in control of what they want to do here, right? And even though, of course, they've been sent by the courts, but they're still in control of what they want to do, right? Exploring ambivalence. I'm not sure I need to be here. I'm not going to argue that. I'm not going to put the label on somebody, right? And then that collaborative goal setting, framing again that the sessions as opportunities, right? So if we go back and we look at what the clinician was saying, right? I hear you on that. You've done what was required, and it sounds like you're feeling frustrated. Really, honing in on what was important to the client. And then you start to get information. Now the person is, again, reveals a lot of information here. I've been sober for a whole year. I hadn't, not sober, but I hadn't been in trouble for a whole year, right? And so, once again, listening and hearing that, and exploring that in an open way, but also look at here, one night led to some pretty big consequences for you, court, probation, and this program. What do you think led up to that? And really getting underneath the hood with this individual about what was really going on. Now, you got to remember here that we've got information about this dude, and this guy has a really complex history. He's probably still dealing with shame and guilt, right, from the sexual abuse. He's got to deal with his bipolar disorder. He's got depression. So there's a lot of things going on there. And we didn't get into any of that here, just kind of let's hang on until we make this solid step forward. And again, affirming the honesty, right? So, you can, the feeling that you might get with a good MI conversation is that there's an openness there and an opportunity for continued growth rather than, oh gosh, that's a resistant client. Okay. All right, we got one more, and we're going to ask our actors to go into this. So this case example is Aaliyah, and Aaliyah is a 22-year-old mother, and she's had 2 children removed due to a marijuana-related legal issue. She's ambivalent about entering therapy as a requirement to get her children back. She's been using marijuana to handle anxiety since her partner David left her and the children 6 months ago. So this is our setup for Aaliyah. All right. Are you guys going to take the same roles?
Sure.
Okay. All right.
Thanks for coming in today. I understand a lot has been happening in your life recently. Can you tell me a bit about what brings you here?
Well, CPS took my kids after I got cited for weed. They say I have to do therapy to even start thinking about getting them back. I'm not sure how I feel about all of that. They said I endangered my kids. I've never, ever put my kids in danger.
Your kids are important to you. It sounds like you're feeling unsure about the therapy, even though getting your children back is really important to you.
Yeah, I mean, I want them back more than anything. They are my life. But therapy, I don't know if it's really going to help. I was just smoking to deal with stress, not hurting anyone. I never smoked around my kids.
Your kids are your priority. You use marijuana to cope with stress, and from your view, it wasn't causing harm. At the same time, you're being asked to do something you're not sure you need just to get your kids back.
Exactly. I feel like they're punishing me, but I also miss my babies so much it hurts.
You're stuck. On one side, you feel unfairly judged, and on the other side, you deeply miss your kids and want them home.
Yeah, every day I wake up and it's like something's missing. I just want to be with them again.
That pain tells me how much you love them and how important they are to you. Can I ask, what would it mean for you to have them back in your life?
Everything. I want to be their mom again, put them to bed, make them dinner, just be there.
You want to be there, not just physically, but fully present for them.
Yeah.
Would it be okay to explore a bit about your worries and what you see as the pros and cons of entering therapy?
Okay. Well, pros, I guess. Maybe it shows I'm trying. Maybe it gets CPS off of my back. Maybe I learned something.
Those are some solid reasons, showing effort, possibly learning something new, and helping move things forward with your case.
Yeah, but the cons, I don't want to be labeled. I don't want someone telling me how to live my life or be a parent. I am a good mom, and what if it's just a waste of time?
You're worried about being judged or forced to change in ways that don't feel right to you, and you're not sure if it will actually help.
Right. I don't want to fake it just to get my kids back, but I also don't want to lose them.
You want to be authentic in this process, not pretend. You want to grow if it's real and helps you be the mom you want to be.
Yeah, I think if it helps me be better for them, maybe it's worth trying.
That sounds like a powerful insight. You're open to therapy if it's something that genuinely helps you grow and support your kids.
Yeah, I guess I'm scared too. Like, what if I fail?
That's a real fear. And at the same time, just being here today, having this conversation shows strength. You haven't given up.
I can't. They need me.
And you're here because you need them too. Would you like to talk more about what therapy could look like on your terms?
Yeah, I think I would.
Great. Thanks again, Chelsea and Mandy. Appreciate that very much. All right, and so there we have our, yes, thank you, Jennifer. Thank you for everyone for giving them that little bit of love there. That's great. All right, and so what did we have here? We had another client who was really ambivalent. He didn't really want to be in therapy, but what was addressed in her situation was something out of the spirit of motivational interviewing, non-judgmental. How can we partner together? The acceptance that was shown, the safety that the person felt safe. So what was going on here in our strategies? There was engaging. The Mandy used all the strategies of engaging, focusing the individual on what's the central issue. What do you want to work on? What's your, and it was definitely ambivalence about therapy, wasn't it? I don't know if I should be here. I'm a good mom. I didn't do anything wrong, right? Drawing out her own motivations. She wants her children back. She misses them. And, but she doesn't want to, she's got that fight within her. I don't want to do this if that, and do something untrue to myself. And that was laid out, I think, in the conversation as well. And then the planning was to begin moving toward considering what are some of the next steps if you would like to do that, right? So asking permission to get what the individual was needed, right? And so the key takeaways from these conversations and kind of the case examples is that once again, we have to have a collaborative approach, right? Because we want them to know that we want to partner with them, that we're going to use PACE, partnership, acceptance, compassion, empowerment. That once again, co-occurring disorders are common. Again, those individuals who are involved with criminal justice involved. And this tool can be very helpful for us to really engage them in a non-judgmental way. And then we really want to support that behavior change by resolving ambivalence and navigating some of the complexities with that. So as we end this, that's the end of the presentation here. I want to make sure that you also get the surveys from this, and we're